Hello, so I'm the only thing standing between you and the rest of your weekend, so I will get going. So this is a cool pathology because it can either be pretty okay and you can just have a headache or neck pain, or you can have a severe stroke. So you kind of have to be very aware of it, hyper aware, in order to diagnose it, or else it gets to you when it's already too late. So we'll kind of cover that. So let's see, we'll talk about the pathophys, epidemiology, some clinical signs, risk factors, diagnostics, including some imaging, but we could have a whole talk just about imaging and dissection. We'll talk about treatment, including hyperacute treatment as well as secondary prevention, although primary and secondary depends on whether you define the problem as the dissection or the problem as having an infarct related to dissection. And then we'll talk about follow-up because all of the patients want to know, what can I do? What can I do? How long do I have to take this aspirin for? And a lot of the times we don't really know what to say, right? So we'll start with a case. The images are kind of wonky because they're actual patients that I've seen, and not all of the images are from within our system, so bear with me. So a 32-year-old healthy triathlete, it took me a while to spell that word correctly. So while doing shoulder press, he noted acute onset severe right neck pain. He didn't do anything about it because he's a triathlete. He went swimming the next day because it was swimming day, and he noted worsening right neck pain, numbness in the posterior torso, his words from the rhomboids to the lower back, and also severe nausea, vomiting, and dizziness that he lived with for 2 to 3 days that eventually resolved. Finally, he went to his primary care doctor, who ordered an MRI brain that showed a right cerebellar lesion that they were concerned was actually a mass lesion, and so he was referred to neurosurgery. He saw one of our neurosurgeons who was more concerned for infarct, and then vascular neurology became involved. At that point, his exam was normal, maybe some mild ataxia, but not anything that was really debilitating, and he felt well at that point. So he had a CTA head and neck that in the emergency room that showed, let's see, here we go, that showed maybe, hypoplastic right vertebral artery with some irregularity, and you have to bear with me, in the V2 segment at C3, C4. And because there wasn't 100% slam dunk about whether or not it was a dissection, he had an MRI with FAT-SAT, which is the ideal imaging, that showed this crescentic kind of thing. You see, this is like the normal vert on the left, and then this crescentic kind of outline that's not supposed to be there on the right. And so that was pretty slam dunk for a dissection. So given the location of where it is, given his clinical presentation, and the fact that he basically had either a stroke, where he had a stroke based on the imaging, it fits with the fact that he had a dissection. So the impression was that he had a dissection. So he had a TCD with emboli detection over the basilar to help determine what his treatment was going to be. And he had no hits on that TCD, so he was discharged on aspirin 81 milligrams. He had follow-up imaging, I think 3 months later. Oh, crud. And I think you can see that you can kind of see a white outline on both, but that's the normal outline, but you no longer see that crescentic signal around the vertebral artery. So it resolved, as most do. He started back cardio, then he started back for swimming, then running, and then eventually he went back to weight training 6 months later, and he's doing great. So why does this matter? What happens when you have a cervical artery dissection? Vessels are complicated, as we all know. So I don't know if you guys remember, all the way back to med school, there's, oh goodness, sorry, it's late. There's all these layers to the vessel, right? And you can have, I think this is probably a better picture, you can usually, the way a dissection occurs, depending on what happens to you, and we'll talk about the risk factors, is you have this intimal flap, which is kind of the initiating step for all these downstream problems. Sometimes you can have just kind of this hematoma without the flap, but that's more rare. But this is where this happens, in the area that's kind of bordering where the blood flow is. Right, so you have this intimal flap, and then that ruptures. You have blood in the layers, in the media. That causes the vessel wall to separate, and you get this area called a false lumen where the blood is building up, and that can cause problems in different ways. If the blood builds up toward the inside, you can start obstructing the lumen of your vessel, and if the blood builds up toward the outside, you can have a pseudoaneurysm or a dissecting aneurysm. right? So what's the problem with that? It may or may not cause a stroke. How does it cause a stroke? So it can cause an infarct by causing mass effect. So how would it cause mass effect? So as you can see here, blood can build up here, cause this false lumen, and this can grow to the point where it's completely blocking your blood flow. Or these little specks of blood can then, break off and go downstream and cause artery-to-artery infarct, which is the most likely way of causing an infarct related to a dissection. And then the area of the dissection is very thrombogenic because you have platelet aggregation of all the different kinds of cells that make it a very thrombogenic situation. So it's not the biggest cause of infarcts in most people, but when you have a young person with the right clinical picture, you have to consider it because in that group of people, it is more likely to be a cause of infarct. It's also likely has a higher prevalence than we know because most people, or a lot of people, don't have an infarct related. They just have a dissection, and then imaging, the right imaging is not always done, so we probably don't pick it up. So when do strokes happen after a dissection? So they usually happen within the first 2 weeks, but overall it's thought that they happen, that your risk of stroke is increased by 2 to 3% in the first 90 days. But basically your highest risk is in those first 2 weeks. What are the predictors of stroke? So a lot of studies have tried to look at this, and the things that stand out that are kind of risk factors that you can't control are male sex, and then I guess tobacco use you can control. But most of them are imaging findings that are all related to whether your lumen is obstructed or not. So if you have an intramural thrombus or an intraluminal thrombus, so intramural would be inside the vessel wall, and then intraluminal is within your true lumen, right? Or if either of those are really occluding your lumen, then that's high risk for having a stroke. If you have intracranial extension, whether it's vertebral or carotid, then that's higher risk for a stroke. If you do a TCD and there are a lot of microemboli signals, then you have higher risk. Vertebral dissection has a higher risk of stroke than carotid dissection. If you have multiple dissections, then you have higher risk, and that probably means that there's something inherently wrong with your vasculature at baseline, and that's why you're probably going to have a higher risk of stroke, and then early recurrent dissection for the same reason. And we'll get into the kind of congenital things in a sec. So how do they present? Again, you may just have headache, facial pain, and they're in different locations based on whether they're carotid or vertebral. So for carotid, you usually will have like frontal, temporal, or neck pain. You can have pulsatile tinnitus. You'll have a partial Horner's, which is how it comes to attention a lot of the times. You can have cranial nerve palsies, which are usually the lower cranial nerves, but there's documented incidences of every cranial nerve essentially being impacted by a carotid dissection. For vertebral dissection, you can have radiculopathy depending on the location. If you can imagine, if you have a V2 dissection, it can affect where the nerves are exiting if there's mass effect. For dissection, the pain usually precedes any ischemic symptom because the pain is signifying where the rupture is happening, growth of an aneurysm, and those types of symptoms. Early diagnosis is key because you may be able to catch the person before they have their infarct, and you can intervene by implementing whatever your treatment is going to be, whether it's an antiplatelet or anticoagulation. Let's see. Well, I don't have that much time left, so I'll speed up. So case 2, 57-year-old man who had a viral GI illness with severe vomiting. He developed a headache. He saw a neurologist who noted a right Horner's. She ordered an MRI brain. He had no infarct. CTA head and neck showed a high right cervical dissection that went into his petrous segment, and it had severe narrowing in the high cervical segment. The MRA head and neck showed basically the same pattern, and he was started on aspirin. He had a TCD with emboli detection that did show emboli over the right MCA, so because of this, he was switched over to Xarelto. He was treated with 3 months of Xarelto and then switched over to aspirin. This case was in 2017, so I think it would be managed a little bit differently now, but we'll talk about that. 1 week after the initial event, he went to the ER for severe headache. He had another MRI, which showed no new stroke. He had a CTA, which showed a stable dissection, but noted that he had developed a pseudoaneurysm. He had another MRI about 3 months later that showed that everything was stable, and then eventually had follow-up imaging that showed that the pseudoaneurysm had improved on its own. So that's another example of how things can progress. So what are the clinical risk factors? So you can have baseline risk factors, and those can aggregate with a minor cervical trauma, and that can be kind of a recipe for a disaster. So there are some things that everybody kind of thinks about, for example, having a connective tissue disorder, but most of the time there are people who probably have a non-specific connective tissue disorder who just are really tall or have hypermobile joints but don't have a defined condition, and those will be the patients that you have, right? There can be anatomical predisposition, so you can have an elongated styloid process, so some people like to measure that on imaging because that may be an intervention if someone's having recurrent dissection, and you can have a surgical procedure to correct that abnormality. There are viral things that can predispose you, so there's an association with flu or COVID in a timely association with having a dissection. And then the minor cervical trauma, which I think is the part that people find most interesting. So we always think about chiropractic maneuvers, right? And I think we tell our patients, if you've had a dissection related to that, never go back to the chiropractor, at least not from here above. But there are other things like economy air travel, which we don't think about. And I think we've all been there, even though we're physicians, right? You are like this on the airplane, and it's really uncomfortable. But I think if you have one of these predisposing factors, it's something to think about. And they do sell, devices and things that help you keep your head more upright, but something that simple, right? Or even turning your head quickly could be a trigger. And then this doesn't cover as much traumatic, but I think inpatient, we've all seen patients in the hospital who have had a car accident or an assault, or unfortunately hanging, who have trauma. So again, there's kind of like a predisposition combined with a minor cervical trauma that can be a recipe for disaster, but it's hard to know who it's going to happen to. So do we screen for anything, essentially? This is from so Dr. Del Ruto's not here, but basically he worked on the scientific statement for AHA that just came out a few months ago with Dr. Yagi, that basically put together all of the guidelines for what we do for cervical artery dissection. And the bottom line is there's not a reason to screen patients unless you have recurrent dissection, unless you think they have a connective tissue disorder, or unless there's a family history. And they give a couple of examples of echo, or if you think somebody has fibromuscular dysplasia, or if they're very young and they have hypertension, then those would be reasons to screen. So imaging, like we said, that could be a whole different talk, but basically the takeaway points are that in the past, digital subtraction angio used to be the gold standard, and we'll talk about some of the pitfalls of that. But I think it's pretty accepted now that MRI FAT-SAT, and CTA, and then ultrasound has some uses, but are really accepted and appropriate for the diagnosis of dissection. So the benefits of MRI, FAT-SAT, and MRA with contrast are that it's highly sensitive and specific. It allows you to see this intramural hematoma on the axial cuts. There is a difficulty in deciding if there's intramural versus intraluminal thrombus, which is important because that may play a role in how you decide to treat the patient. And MRI, FAT-SAT, or MRA may have a difficulty. It's better for carotid dissection than for vertebral dissection, because in the posterior circulation, the venous plexus that kind of surrounds the vertebral arteries may be confused for this like crescentic thing that I showed you, so it could be a little bit tricky. So you may overdiagnose or confuse a dissection when it's not really there. So that's one caveat. CTA may be better for vertebral dissection. These are just some examples of the findings that you can see on CTA. So I think everybody knows about, the flame shape. We also have the string sign, the double lumen. This one's a little bit hard to see. This is a pseudoaneurysm. And then I think it's also important to mention the mimics, right? So, because usually when we're thinking about these patients, we're thinking we still sometimes have a broad differential. It's not always a slam dunk case. So what are the mimics? So a pseudo-occlusion is when you have a clot that's probably more distal, whether it's in the terminal carotid or the MCA, and, oh goodness, and there may be a sluggish column of flow, so it looks like you could potentially confuse this for a flame sign, but it's actually a pseudo-occlusion, and the only way to know that is to have done intracranial vessel imaging and see there's a clot upstream or downstream. You can have a fenestration, which you could confuse for a double lumen on axial imaging. That's why you have to look at all of the planes, right? And then I think the most difficult one is a web, a carotid web, which we don't see that often, but is something that I think we're kind of more open to now and seeing that it's a cause of recurrent stroke. So how do we distinguish with a carotid web based on the location and also the fact that it doesn't change over time, whereas the dissection does change over time? So we can use other things like location to help define or distinguish between dissection and other findings. So for example, where do dissections occur? Carotid dissections tend to occur a little bit downstream of the bifurcation, whereas webs occur a little bit closer to the bifurcation and posteriorly. And athero tends to occur in the bifurcation, and you would likely see athero in other parts of the vasculature that would kind of raise your suspicion that it could be athero versus the dissection. Similar for the vertebrals, right? You see dissections mostly in the V2 and V3 segment, where the vessel is most prone to trauma from the vertebrae, whereas athero you see at the vertebral origin at V1 or at V4 once you're kind of getting intradural. So DSA, like we said, number one, it's invasive. We've already kind of confirmed that the other forms of non-invasive imaging are pretty good at diagnosing, right? And it also has risks, including iatrogenic dissection. So I think a lot of us have seen that we have patients who are working up for stroke, and we find that they've had angios in the past, and we find these small dissections. We don't do too much about them, but that's really the only risk factor in the patient's asymptomatic. So there are risks of doing a dissection, a DSA, and a lot of the times we're able to come to the diagnosis without requiring it. And in terms of TCD, I gave you an example in the cases of how we were able to use it to come to an answer about what treatment we wanted to give the patient. So we're getting to treatment. So for acute treatment, and I'll go a little faster because we don't have that much time. Basically, when a patient comes in with acute symptoms and you think that their cause is a dissection, the fact that you think it's a dissection is not a contraindication if they qualify for, by guidelines for either tenecteplase or endovascular therapy. So if they qualify based on criteria, then they should be a candidate for those therapies. Another thing that's a little bit important to think about is if somebody has a dissection and they have a near occlusion and you think that that's giving them symptoms, for example, if they're hypoperfusing or if they have a near occlusion and let's say a clot downstream, they may need a stent if they haven't responded to medical therapy. And the bottom line is the recommendations say that that's pretty reasonable depending on how they've responded to medical therapy. So I think people are most worried about what do you do in the long term once the patient is stabilized, in part because there's more equipoise about that, and also because most patients don't show up acutely just because of the nature of the illness. And so there have been a lot of trials that have tried to focus on this, but basically just to summarize, the first trial that was CADIS, that came out a little bit before 2019, but it was published in 2019, and essentially it was underpowered. It was a trial that looked at patients who had dissection. Not all of them had had stroke, and I think that they kind of assumed that there would be many more strokes, but there weren't as many strokes as they expected. And so it's really underpowered, and there was no difference between patients who are on antiplatelet or anticoagulation. Then there was TREAT-CAD that was more recent, and it was a non-inferiority trial, and it was a different setup, but essentially aspirin was not non-inferior. So that really left us with not a lot of good information. And essentially, I think the general practice, to summarize, that we were at least using at is that if there was a vessel that had a thrombus within it, so an intraluminal thrombus, most people would anticoagulate for about 3 months, and then we would switch over to antiplatelet, unless the person had a risk of bleeding or they had a very large infarct. If they had a dissection and the lumen was pretty okay, then we would probably do either single or dual antiplatelet, depending on how they came in with their stroke. So I don't know if everybody agrees with that, but I think that's what we were mostly doing. So their newest trial is STOP-CAD. It's not published yet. It was just discussed at ISC 2024, and it's observational retrospective. It was done in 16 countries, and basically they looked at kind of what have people been doing with dissections and how's it been going, right? And the outcomes were acute ischemic stroke in the artery, in the territory of the dissected vessel, and then of course they looked at hemorrhage, not just intracranial, but excuse me, major extracranial hemorrhage. So by 180 days, there were 162 strokes. Most of them were in the antiplatelet group, 130 versus 32 in the anticoagulation group. Most of the strokes occurred within the first 30 days, which is interesting and consistent with all of the other studies. There were 28 major hemorrhages, 16 in the antiplatelet group and 12 in the anticoagulation. And acute ischemic strokes were lower with the anticoagulation group, but it was not significant. So essentially, there was no difference. In terms of major hemorrhage, there was no difference at 30 days, but when they looked at 180 days, there was a higher bleeding risk with anticoagulation. They did an interaction analysis that basically kind of confirmed what we knew from our practice, that if it's occluded, then you may have a benefit with anticoagulation. So combining those two ideas, that there may be a benefit if the vessel is occluded, but there's a higher bleeding risk if you for greater than 30 days, they kind of came up with saying that you should take an individualized approach, which I think is safe and what we were doing anyway. So it kind of confirmed our practice. So they came up with this algorithm, which I think is helpful and helps people be more consistent, right? So it's still a little vague because I think the questions are, what do these things mean? What is moderate bleeding risk? What is low bleeding risk, right? And those are not defined. I think this is kind of individual. Is it a GI bleed? Is it somebody that has, rectal polyps? It's really individual, right? Is it somebody that has microbleeds in their brain? It's really up to the interpreter. But basically, if somebody's bleeding risk is not elevated, then they're asking, do you have high-risk radiologic features? So I think you've seen the pattern. High-risk radiologic features are that you have something inside the vessel that's occluding the lumen, right? Intraluminal thrombus, is it narrowed? If you have that, then, and low bleeding risk, then you should probably go for anticoagulation, but probably not longer than 30 days, right? And you can kind of see the pattern. But the goal is, because we have this algorithm now, people can be consistent, right? So I think this is the last slide I'll have. So I think you guys remember Dr. Astaghi mentioned this morning with cerebral vein thrombosis that in the past we kind of just used to put people on anticoagulation and then on aspirin, and then we used to leave them on aspirin forever because we didn't really know what to do. I think with dissection, it's been a similar idea. You either put them on aspirin or you put them on anticoagulation and then switch them to aspirin, and we don't really know when to stop, right? Just kind of leave them there indefinitely. But I think this, these guidelines or this statement is really the first to say a time frame, and so that gives us something to work with. So they're saying that 3 to 6 months is reasonable. What do you do after that? It really depends on the person, right? So if somebody has, let's say, a pseudoaneurysm where you think that there's tortuous flow that still puts them at risk for infarct, you may want to keep them on aspirin, right? So again, not a lot of information, but something to consider. What do you tell patients about what they should go back to doing? It depends on if you think they have an underlying connective tissue disorder, and that, it depends on whether or not you think they need to be worked up, but most people can probably go back to doing what they were doing within 6 months, right? And I think that's fair to say to them. But again, this provides you some guidance to be able to give them. And then in terms of imaging, there really aren't any standards for when to repeat imaging. But again, it depends on whether or not they had those high-risk features to start with. So the takeaway points from our cases were, I think we'll skip that, but basically the other reminder is that you also have to treat the headache, right? Because that's very debilitating for the patients, in addition to treating their stroke symptoms. And I'll leave you with the takeaways. Thanks.